You bought a glucometer for your office, now what? This is a presentation by Brian O'Glander, Southwest Oral Surgery Education at Your Fingertips. We're going to familiarize you with the glucometer you may have purchased for your office and run through some steps for usage and some information on how you can implement this in your practice. How does the glucose monitor work? First of all, there's a test strip that contains glucose oxidase. This is an enzyme that reacts with glucose in the blood. When the test strip comes in contact with blood, that blood is taken up by the strip. There's an interface now for that blood from the test strip to an electrode inside the glucometer, i.e. the greater the glucose level in the blood, the higher the electrical flux in this glucometer, and i.e. a higher number of your blood glucose level. Cost for the system. If you've purchased the glucometer already, you know that the glucometers are around $20 to $30. Sometimes the test strips can be an expense, so you want to make sure you purchase the correct test strips for the glucometer that you purchased. Reasonable expense is about $10 here. These glucometers run on a lithium-ion battery. The duration you should get out of your unit should be at least 2 to 5 years. You get a pretty decent lifetime because we're generally going to be using this infrequently. The glucometers are easy to use as well, as we're going to see. Steps, first of all, you want to at least clean the area you're going to sample. Remember, we're taking our capillary blood glucose level. We're either doing a pinprick in the fingertip or on the side of the finger. We can use an alcohol prep pad to clean the area. Better yet, if we're not in an emergent situation, we would have the patient wash their hands. There have been studies that show patients that have been working with fruits, they will show an elevated blood glucose level. This would be more important if we were using our glucometer more for screening and measuring our blood glucose throughout the day. Step, we've lined out everything that you have with your glucometer kit. Far left, you'll see our lancet as well as our lancet delivery device. This is how we're going to actually obtain our capillary blood glucose. Right in the middle here is the actual glucometer. This one we purchased at Walgreens. This is a true metric. To the right of that is the test strip. The area that's darker gray at the bottom, that is actually what goes into the unit, and the smaller, thinner gray bar, that is what will come in contact with the blood. Far right, that is the actual lancet that is going to go into the apparatus that we're going to use to obtain our blood glucose. We'll show you this step here in a second. Here is the lancet device. We've introduced the blue portion into the lancet device by opening it, simply pulling the lancet apart. Once that blue piece is inserted, we pull off the protective end, replace our cap back on it, and now you see there's some numbers here. We see 2, 3, and 4. That's the depth of penetration. You can set it to 3 or 4, and you should get a decent pinprick so that you can sample your capillary blood glucose. Next, you want to make sure you're ready to deliver the needle, so you pull the apparatus apart. That's the upper right image. And then finally, sampling capillary blood glucose. We've got this pointed at the edge of the fingertip, and there's a button that activates this. You see that button on the upper left. That's that really dark gray button. You press that, and you get a little pinch to your finger. Here we have our blood glucose machine. The machine turns on the instant the test strip is inserted. We put the test strip in contact with blood. That blood is sucked up by the test strip. Now the machine's going to go to work, and then we'll get a number. And i.e., now we have our capillary blood glucose, and we know if our patient is hypo or hyperglycemic. Normal numbers, a normal fasting plasma glucose level is less than 100 milligrams per deciliter. A normal 2-hour postprandial, or after somebody has eaten, glucose level is around 140 or a little bit lower. Abnormal values. On the low end, less than 60 milligrams per deciliter. That's somebody with signs and symptoms of shakiness, rapid heart rate. That's a hypoglycemic picture. And if we're under 15 grams per deciliter, the central nervous system dysfunction, loss of consciousness, unresponsiveness, that's because the brain is relying on glucose as a substrate. So we're going to start to see our signs and symptoms with somebody's blood glucose 60 milligrams per deciliter or lower. On the high end, the high level, anything greater than 180 to 200 milligrams per deciliter probably means poor glycemic control. Your glucometer is still not the best screening tool for diabetes. A normal glucometer reading frequently does not indicate the absence of diabetes, because many people with undiagnosed diabetes have normal blood sugar values at some point in the day. We're not using it yet for screening in our office. This is a quick way for us to determine if somebody is hypoglycemic, or say we're doing a procedure, we just want to know what their blood glucose level is and they're diabetic. Quick way for us to check that. So if you're planning a procedural appointment, it may be wise to know what's called the hemoglobin A1C as well as the capillary blood glucose level. Now, you're not going to get the hemoglobin A1C from any glucometer that you have in your office. That's something you're going to have to check with the physician, but the hemoglobin A1C is a more accurate level or picture of the glucose concentration over the previous 3 months before the blood was drawn. So as you see here in this lower right corner, this image here, the hemoglobin A1C is a percentage of hemoglobin glycolated or bound to glucose. This gives us a better long-range picture of how well somebody's glucose has been managed. So if you're looking at doing a procedure on somebody, it's important to check their blood glucose. They're diabetic prior to the procedure, but even before that, at your consultation or initial evaluation appointment, if they're diabetic, check with their physician, get a hemoglobin A1C. It gives you a little bit more information about how well they've been controlled. You see here, if you know somebody's hemoglobin A1C, you get a good level of how they're managing their diabetes. Most primary physicians strive for a hemoglobin A1C less than 7. That's the goal for patients with diabetes. You can use your hemoglobin A1C and kind of get an estimated average for what their glucose has been. Generally, patients with a hemoglobin A1C of 7, their blood glucose has been around 150. If it's greater than 8, 9, 10, we see that their blood glucose has been up and has been elevated, so they're probably poorly controlling their diabetes. So you're hoping that if you have a diabetic patient, that their hemoglobin A1C has been around the 7 level. The lower the hemoglobin A1C, the greater the risk for the patient to develop low blood sugar in their office. In people without diabetes, symptoms of hypoglycemia usually do not occur until the glucose level decreases to less than about 60 milligrams per deciliter. However, your hypoglycemic symptoms may appear in your diabetic patients at levels a little bit higher than that. Clinical pearls for you in your office: look for a glucose level around 100 milligrams per deciliter. This is usually okay for most short procedures, things less than an hour. If you have a diabetic patient who is presenting for some procedure in your office and their blood glucose is less than 100, you may want them to drink some fruit juice or use a glucose tablet or two to raise their blood glucose level, hopefully around 30 or 40 milligrams per deciliter, so you get them back up to around 100. Remember, glucose does not absorb through your mucous membrane, so if you're having this patient suck on a glucose tablet, that actually has to seep down into the stomach. If you're going to use your Instaglucose, if you're going to put that in the vestibule, that still has to seep into the stomach to be effective. If you have a patient who's unresponsive and you suspect or know hypoglycemia is the issue, this is an emergent problem. This is something we want to activate EMS for. Thanks for listening. Go ahead and keep reading the material, and thanks again.